Hello and welcome back to Prescribe Orally. It's your host, Shatner.
And Chris.
And today we're going to be discussing about seizures and...
more accurately,
epilepsy. So,
Sit back, relax, listen to us medical students, try and revise the topic we haven't covered yet. Join us on the journey.
Grab your coffee.
I've drank all of mine. But anyway. Alrighty. So, what is epilepsy?
So, epilepsy is it's like a broad term used to describe a condition like that where you have a tendency to have seizures.
Ooh.
Am I right in saying that, Chris?
I would say so. And seizures are episodes of abnormal electrical activity
in the brain.
Yeah.
In the brain, you know.
And we'll get to all the different types.
All the different types soon. So basically the diagnosis of epilepsy is done through characteristics of a seizure episode.
Yeah, so like the clinical sort of history is always 80% of your diagnosis comes from the history.
Yeah, you cannot rely on EEG. It's on a clinical basis based on history.
Yeah.
And how do you take a history from someone who's had a seizure?
You kind of just start from, when did this happen? You go through your predromal, so pre-seizure.
Yeah.
Your peridromal.
Peridromal, yep.
During the seizure.
During the seizure, yep.
So you may need sort of a bystander or a family member to be also there to sort of tell you what happened during that seizure.
Yeah.
And then the post dictal period, so the time after the seizure, how long did it take them to sort of not feel groggy anymore? Did they find that they were, incontinent. After that? Things like that there. So it is important just to get that sort of history beforehand.
You realistically need a good history from the bystander as well whenever you're doing, these, whenever you're trying to make a diagnosis of epilepsy.
Aye.
Okay. So, one of the main investigations are I don't know if we've mentioned it yet, but EEGs.
Yeah.
And it's an electroencephalogram.
Try it again.
Electroencephalogram.
Wow.
Oh, wow.
Which basically is like an ECG for the brain. You get to see the electrical waves going on in the brain. And there's, you'll get, as medical students, we'll get questions that ask us on like the type of spike pattern that you would come across. I personally haven't learned any of those. I think a lot of the time when you're in these questions, they give you a good history anyway. Yeah. But again, if you're top 90%, I am not.
Neither am I. So
maybe you do want to learn those. Yeah. I feel like there's more high yield stuff that you could be learning.
And if you're a neurology consultant, you definitely want to learn those.
Good job.
And and an MRI is also used to visualize the structure of the brain.
And you can get any like structural abnormalities, things like that, ruled out
to relate to the seizures. Yeah. Okay, so another investigations would be like an ECG for your heart as well. Just
so you do have your sort of non-seizure like sort of differentials that you can go through, with sort of cardiology problems or of like syncope, things like that there. Breath holding seizures, that's when you have wee kids that are panicking, they're crying, and then get so worked up that they faint and then can actually have sort of seizure like episodes. So like there's a plethora of differential diagnoses for these seizures, but we could talk
all day about it.
So we'll get to the
main point, the types of seizures. Do you want to start with this first one?
Well, so you've got your you can sort them into generalized and focal. Generalized tonic-clonic seizures are seizures that are affecting the whole brain. You'll see abnormal electrical activity over the whole brain, and this will result in your tonic-clonic movement, which is...
So tonic means muscle tensing, and clonic means muscle jerking.
So that, when you typically think of a seizure, you think of the shaking on the ground, the jerkiness, biting the tongue, things like that there.
Yeah.
So that is your typical, when you say someone what is a seizure, they'll think of that.
One thing to remember is like the tonic phase comes before the clonic phase. And
and then during these seizures in particular, you would get quite a prolonged postictal period. So these patients will be very tired and fatigued and confused, typically after these tonic-clonic episodes, just because it's a lot of stress.
It's a lot of stress in the body, and we also have. So when we were coming to talk about focal seizures, they usually start in the temporal lobes. They can affect hearing, speech, memory, and emotions.
And all these are you can kind of think of these as what region of the brain. This focal or partial seizure comes from. So
we're gonna go through like the different regions of the brain and how it can affect how the seizures can be affected.
We get nice wee brain set up right here.
Yeah, well, nice wee brain. So the
really
frontal
big
lobe,
one like mine.
So I'm just gonna the frontal lobe here, right?
No, I want to do the frontal lobe over here.
The frontal lobe over here. Okay, so that's where the motor phenomena. So anything to do with your jerkiness and like sort of motor symptoms, such as Jacksonian's
movement. So that's like quite I think from memory that's a marching type of movement. And let's see, what else is there? Like lip smacking involved in that one, or is that in the other type of seizure?
No. So if you think about it, like what does the frontal lobe of the brain do, like realistically? So it's like Todd's palsy, dysphagia, all that scenarios. And you're talking about Jacksonians, are you? Lip biting?
Yeah. So so it's predictable pattern of twitching and tingling sensation that only occurs on one side.
Okay.
Which I guess that makes sense. You have your sort of crossing of the brain, left brain controls right side, things like that there. But
and on the temporal lobe, that's where your lip smacking comes in.
Oh, right, okay.
So like temporal lobe, automatisms, which is examples of it.
Automatism. Oh, jeez. It's
too
early.
And,
why do I record this early?
So like olfactory, gustatory, or auditory hallucinations can also be involved with your temporal.
Well, I think like your temporal is sort of, that area is for, you've got your
temporal lobe
area and your auditory areas there. So you'll get those symptoms. Also, really strangely, you'll get patients will get a sense of deja vu or jamais vu.
Jamais vu.
All you French linguists can. So deja vu is the experience of I have experienced this before. Jamais vu, jamais is never in French, meaning this is someone who thinks that they have never experienced this before.
Interesting. Wow. That's cool.
French GCSE did not fail me.
And so whenever we go to partial lobe, we're moving from the front of the brain to the back. So like partial
parietal. It's too early.
It's too early.
It's too early.
It's too early. Partial lobe. I was thinking about partial seizures there. Yeah, sorry.
I get you.
Parietal lobe would have your sensory symptoms, such as your tingling and numbness. Also, there's some motor symptoms involved. That's because like of the electrical activity,
it like
spreading from the precentral gyrus of the temporal lobe.
Okay.
Not the temporal lobe, frontal lobe.
Oh yeah, because you've got your
precentral. Yeah. So it just transfers over, and that's why they can have some motor symptoms. Okay. And at the back, your occipital lobe,
which quite self-explanatory.
Yeah,
you'll get
visual
your
symptoms.
Visual symptoms. So
spots
this is
and lines in the field, wiggly lines, spots.
Kind of like your aura that you'd get with migraines type of
migraines.
Stuff. But yeah, so we've covered our partial focal seizures. We do have a list of our generalized seizures.
Yeah, we can do.
So we've covered the tonic-clonic already.
So do you want to run through absent seizures there?
So absent seizures are your sort of, you'll get this typically in kids where they may just kind of space out and go completely, like, have a brief pause. They may sort of have their eyes roll into the back of their heads, just completely unaware they are absent, hence the name.
Yeah.
And then from there we have our infantile spasms, which is just, your younger kids having, or aka called West syndrome.
So absence seizures, like,
I thought you took a blank there. I actually thought that you didn't know where you were going with that.
No,
but no,
like,
you
I
were
was just-
actually having an
yeah.
absence seizure.
I was just trying to demonstrate like that. That's what it's like. Isn't it?
That worried me slightly.
What were you gonna do? What was the management you were gonna do, me?
Oof, we'll get to that later.
Okay.
On. We'll get to that later on.
So
that was unfair.
We're gonna move on to atonic seizures.
Yes.
So that's just your drop attacks.
Yeah, sudden fall to the floor and
brief lapses in the muscle tone. So
Aye.
whenever your muscle tones feel lax, yeah.
It looks like a lot like a sort of faint, but they can often have a myoclonic jerk along with this.
Yeah, and they typically don't last more than 3 minutes.
Okay.
And they usually begins in the childhood. Yeah, this may be indicative of some crazy syndrome. Not crazy, like it just Lennox Gestalt syndrome. I don't think that's probably a high yield information. Probably won't need
Lennox
that.
Gestalt syndrome. Yeah. Interesting.
Which I don't know what it is. Athen, put a description here. I'm not searching it.
No, that's too much for my little brain.
And myoclonic seizures, just whenever we thought about atonic, think about like
they fall to the floor, whereas your myoclonic
it's like a sudden jump.
They like kind of leap.
Yeah.
So they'll tense, leap up, and then hit the dirt.
Yeah, it's muscle contraction. So and they occur in. It's pretty much like in a lot of epilepsy, in various forms of epilepsy, and in kids, it's pretty interesting because like these happen as a part of a juvenile myoclonic epilepsy.
Okay. Yeah. Okay. So that's your differential in that situation when you've got that sort of clinical picture of, I saw my kid playing and then suddenly it's like they jumped in the air and fell on the floor. Yeah. That's one sort of differential to keep in mind.
And infantile spasms, you already went through it. Yeah. It's also known as the West syndrome. Yeah. Just in case you were curious. And
1 in 4,000.
1 in 4,000, yeah.
So that's a cluster of full body spasms. Yeah. And unfortunately has quite a poor prognosis. Yeah. And are quite difficult to treat. And we will get to the treatment with all these sort of conditions soon. So just a quick recap of all our generalized seizures. We have our 5. We have tonic-clonic. We have our absence, we have our myoclonic, we have our tonic, and we have our atonic. 5.
That sounds about right.
Boom. Easy. And we'll have a list here because it's difficult to remember all of them.
They're quite easy to forget. No, I was just going to say they're quite easy to remember. Correct me if I'm correct.
See the previous podcast. Yeah. Shannon speaks nonsense.
Yeah, so we are going to move on to the medication for different types of seizures.
Mm-hmm. So it's actually quite easy to remember as well.
Just summarize it in like one sentence, Chris. It's I didn't know. I didn't think about this way.
When you think of a generalized seizure, always think of sodium valproate as the first line. Yeah. If you think of focal seizures, think of carbamazepine first line.
Carbamazepine.
Yes.
Thank you for letting me. Yeah. Teaching me how to pronounce it.
Carbamazepine.
Yeah.
So
no, that's fine.
Generalized sodium valproate, focal or partial. Yeah. Carbamazepine. Obviously, you then have your second lines, which we can get to eventually. But just to keep things nice and simple for now. Okay.
And so we're gonna give a quick run through of these medications.
Oh, are we?
Okay. Yeah.
Oh gosh, I hope you take the wheel on this one.
Sodium valproate. It's a first line option, like Chris mentioned, for most forms of epilepsy. except for focal seizures. I'm just trying to reiterate that. So these work by increasing the activity of GABA. Am I right in saying that?
Yeah, GABA receptors.
I'm a pro.
Your class.
And has a relaxing effect on the brain.
Interesting.
So one of the biggest side effects to think about whenever you're prescribing sodium valproate is the person pregnant, because it's because this is teratogenic.
Good job.
And the patient would need careful advice about contraception.
Yeah.
You know, liver damage, because this is what?
It's a cytochrome P450.
P450, yeah.
Yeah.
So you need to remember, we'll cover that in another podcast about enzyme inducers and all that jazz.
Gosh, okay.
All that jazz.
Worrying me.
So, yep. Hair loss is pretty common. Not common, like it's a notable side effect.
Yeah.
And tremor is a notable side effect.
A helpful way of remembering the side effects for valproate is you can use each letter. So V, valproate side effects. A, appetite increase and weight gain.
L, liver failure.
Pancreatitis for P.
Reversible hair loss for R.
Nice. Edema.
Yep.
And then ataxia,
teratogenicity,
tremor, and thrombocytopenia.
And also encephalopathy.
So confusion due to elevated ammonia.
Yeah.
So.
Yep. And then when we're moving on to carbamazepine.
Covered this, bro.
This is why. So it is a sodium channel blocker.
Yes.
So it has and it's also a strong hepatic enzyme inducer.
Yes.
So
and your notable side effects for this is your agranulocytosis, your aplastic anemia, and then obviously the interactions with the liver, other liver metabolized drugs.
So
quite frequently in like your question banks, you'll get asked like, this patient's got a history of epilepsy, and they have a type of anemia. They've been investigated for anemia. What medication are they using? So it's important to remember carbamazepine. I think carbamazepine has 3 A's in it. So think of the agranulocytosis and aplastic anemia. AAA. Agranulocytosis, aplastic anemia. Okay. AAA.
Don't confuse it with AAA.
Yeah.
And you're moving on to phenytoin, which
sodium channel blocker.
Another sodium channel blocker. I actually didn't know that. Probably should have looked at that one. Notable side effects involve the folate and vitamin D deficiency because of the pathway it's working at. Would that be right?
I'm unsure, to be completely
just
honest.
Buy it, bro.
Oh yeah,
just buy it. Sweet. Okay, no worries. And megaloblastic anemia, which again relates to folate deficiency. Also osteomalacia.
Yeah.
Which relates to vitamin D.
Osteomalacia is due to your vitamin D deficiency. So just think of your phenytoin affects folate and vitamin D, therefore you'll get your anemia from that and your osteomalacia from that.
Oh, okay.
Yeah.
That's interesting. That's right. And lamotrigine, which is another big one.
Yeah.
We need to
noticeable side effects: Stevens-Johnson syndrome or Duress syndrome. These are very sort of serious skin reactions you can get.
Yeah.
I think that the lamotrigine is one of the sort of ones that you would tend to use more with women who are pregnant. Correct?
Yeah. How did you think that suddenly?
Because I remember L's.
Yeah. That's good.
Yeah, so lamotrigine, levetiracetam are used in pregnant ladies.
Pregnant ladies, okay. Sounds good. Good. And leukopenia. That's another notable side effect.
And what's that?
Leukopenia means less immune cells, right?
I believe so. It is a decreased number of leukocytes, white cells. Good job.
Past medicine. So when are you giving me my degree in medical MBBS, BCH, BAO?
Pardon?
It's your bachelor's you're going to get when you graduate, bro.
Okay. I did not know that. So yeah. Right. Status epilepticus now. What is that?
It's defined as a seizure that's lasting more than 5 minutes or more than 3 seizures.
This is like your main
definition.
worry of those with epilepsy is the status epilepticus. So just prolonged seizures. So for more than 5 minutes or 3 seizures within 1 hour.
Yeah.
And this is a medical emergency. Therefore, you take the ABCDE approach.
Yep. So you secure the airway.
Yep.
Give them oxygen, high concentration oxygen. Assess the cardiac and respiratory function. Check the blood glucose. What else? Intravenous cannulation, and then you give them IV lorazepam.
Yeah. Provided you have IV access. So in the situation where this patient is in a community setting, they don't have any IV access, you either use buccal midazolam or
rectal diazepam. Yeah.
And after 2 failed attempts of your diazepams, then you elevate to phenytoin as your
IV phenytoin.
Yeah.
So it's the same for IV lorazepam. You know,
really?
if you repeat it after 10 minutes, so you get 2 IV lorazepams, 4 mg lorazepams, and then if it still persists, you move on to IV phenytoin.
You elevate to that point.
But
excellent.
That is pretty much
that's epilepticus.
Yeah, just to summarize, epilepsy is a broad term given to a condition,
chronic disease where patients will have seizures.
And 5 types of seizures.
Well, 5 types of generalized seizures. Your tonic-clonic, your absence,
your myoclonic,
yeah, your
atonic,
and your tonic. Yeah, basically tone. If you use that, you can kind of understand what they mean. So atonic means that they don't have tone, so they're floppy. Tonic means they do have tone, so they're all tensed up.
Yeah. And with medication, you need to think about, you don't give pretty much for all sort of all generalized. You give sodium valproate.
Yeah, and then for focals,
for focals, you give
carbamazepine.
Carbamazepine.
You didn't want to say it, did you?
Flip.
Alrighty, and then with your focal seizures, you can think of the areas of the brain that are affected. So your frontal is your more motor dysfunctions. Parietal, you get your sensory dysfunction on the opposite side. And can get into your sort of motor stuff. Temporal is your hearing and
auditory hallucinations.
And your
deja vu.
Deja vu, jamais
vu, and your ox.
You don't pronounce it.
Jamais vu, and oui, and occipital.
Your visual stuff. Yeah.
That summarizes it all, I think. Doesn't it? Aye. Sure.
Perfect. All right, guys. Well, thanks very much for listening to this episode of the podcast.
We're on Spotify. We're on YouTube. If you like watching the videos, you can watch it in both.
We'll be on TikTok and Instagram by the time this one comes out as well.
Hopefully,
if we,
actually make it.
Yeah, if we try and put in some effort and.
Yeah, but that's pretty much us for today.
Get things going. It's been like 3 weeks. We haven't done this.
Loads of love.
Peace out, guys.
Peace out.